Bueno, buenas tardes a todos.
Hello, good afternoon, everyone. We will begin with the next panel, Reproductive Health, Justice, and Rights. We are going to welcome with the second speaker on our agenda, Beth MacFife. She's a magister at the University of Oregon, USA. Bex, are you ready?
Yeah, sure. Hello. Hi, everyone. Good morning. This is me speaking, maybe for the first time today. Spoiler alert. All right. Hello, everyone. Like my introducer said, my name is Bex MacFife. I use she and they pronouns interchangeably, and I'm contacting you from Kalapuya, unceded territory in Oregon, where I'm a student at the University of Oregon, a doctoral student in sociology. And I have a background as a sexuality educator. I think that I'm still doing that, but now it's through academia instead of in schools. I wanted to come join this wonderful event to talk through gynecological teaching associates and how they intersect with trans and queer identities. So how this is going to go, I'm going to start by explaining sort of some of the context. Most of us seem to be on the same page about what's happening in terms of trans health. But in terms of medical education or healthcare professions education and training and trans identities, then I'll move into talking about gynecological teaching associates before getting into my own research about queer and non-binary and trans people who are doing that work. So to start off, it seems we're all on the same page. Like I mentioned, that there is stigma in healthcare and that there are healthcare disparities, especially for trans and non-binary folk. Instead of diving into that, like a lot of other people have been really great covering those things, I'm going to be talking about healthcare. One thing that contributes to the inequalities is that in training medical providers, there's not a lot of trans awareness or information going on. Part of that is because something that's come up as an issue before is that it's considered a specialty. It's considered a niche area to be working in trans medicine because we're rare, right? Because why put a lot of time into working with a population that you may never come across? That's of course false and not helpful for working with people. If it does come up, it will maybe be through an elective on LGBTQ healthcare. Noticing that trans and LGBTQIA identities are all put together, maybe into a one-off lecture for half a day. There can be patient panels that come in where people talk about their experiences, but there are risks to that. It's definitely important and we should be doing it, but it's, as one of my participants says, I don't know if it's possible to be trans competent if you're not trans yourself. So if you go to a competency training, you might leave thinking that, oh, that's everything I need to know about trans people, when we know that's not the case. Gynecological teaching associates, I will be referring to them as GTAs, are educators who work in medical education, but in kind of a non-traditional and not very well-known way. So they are not doctors themselves. They haven't been through the socialization of becoming medical providers. They are lay people who have been specially trained to teach pelvic and breast examination, breast and chest examination to students of healthcare. So what's fascinating and kind of beautiful and has a lot of radical potential in this job is that they provide instant feedback by modeling on their own bodies. So they'll teach students how to perform these exams, which includes speculum exams, bimanual exams, visual vulva examination, etc. And then they will invite their students to practice it on their own bodies while they coach them through it. So as it is, it's switching up some of the power hierarchies between patient and provider in some pretty cool ways. I think I'm a little biased. So 72% of US MD programs use GTAs. You may notice that I'm focusing in on the United States. I know that there are programs in other places that do similar things, but for my research, this is where I focus. And I'm also, this statistic is talking about MD programs. GTAs are also used in NP, DO, PA, all sorts of other healthcare professions, but has not been as well researched. And it's hard to research GTAs because there are so many different programs across the country and across the world, really, where some of them are housed in medical schools, some of them are independent organizations, and that makes it challenging to study. And there's not a lot of communication necessarily between the different programs, which means there's a lot of variability between them. How it might work, usually it's 3 students for 1 to 3 hours. Sometimes there's a sexual history taking and a patient interview component, and sometimes it's just the more technical skills. Sometimes the pelvic examination happens separately from the chest or breast examination, and sometimes they're combined together, which has consequences if you're thinking about trans people doing this work. Folks who've had surgeries may or may not be eligible. That's part of what I'm going to question, is that eligibility piece that I hear from some medical programs. So with my sociological training, I got my data here from interviewing 25 GTAs. They represented 6 different programs across the country, across the US. 7 of them identified as trans or non-binary, 14 identified as queer, and 15 identified as white. In order to give you a sense of the racial makeup, it tends to be a lot of older white women in some places and a lot more queer people in other places. I also want to acknowledge an autoethnographic component. This is a job that I care about a lot, in part because it's a job that I have and that I do. So I've been a GTA myself for the last 6 years with a program that has happened. My skill in this work has happened in conjunction with some development of my own gender identity, which is why it's very personal, and which is part of why I'm so invested in looking at how this can be mobilized even further than it is right now. There's a lot of pedagogical opportunity that I've been talking about. For one, they're the small group workshop intensives. So a downside of that is that you may only interact with a group of students once in their career for up to 3 hours, maybe 5 hours at most. But that also means that it's very personal. There are no faculty present. It's just the students and the instructor. That's something that's shared across most programs because they found that if there is a faculty present, then the students are trying to be sort of in a classroom setting as opposed to just sort of having an experience. It's also not graded, so it's purely experiential, or at least that's the goal. The focus is on normal and healthy. I put quotes over normal and healthy because there is plenty to be suspicious of there. What is normal and what is healthy and who decides that. But that is a common refrain that is used during these examinations or during these sessions. Which is to say that they're routine examinations. You're not expecting there to be a cancer or a problem. You're doing a routine, usually it's a routine pap smear. So you're anticipating a baseline instead of looking for medical issues. That allows an opportunity to if there is something happening, some pathological problem that you need to look into as a medical provider, then you will have this to compare it to, is the idea. The multiple forms of knowledge come from not being a layperson, so having that experiential patient piece a little bit more than being sometimes inculcated or indoctrinated into some of the medical provider healthcare system thinking. You also have haptic knowledge or embodied knowledge, which means that you know your own body. I can point to my ovaries in a very short amount of time. So that's something that medical schools need, especially for such a charged exam, which is, I think it's an opportunity. People pay attention a lot more if they're nervous, if it's something that doesn't commonly happen. But that might mean that for some people, they're so nervous that they don't really take in information. That's part of what I want to look into more in my research. And then if you're thinking about having queer people and trans and non-binary people coming in and doing this work, that just adds another level of knowledge. It means you have lived experience and you have community potentially with other trans people. So you're bringing in that component to what a cis, white, straight, hetero woman might bring. In my findings, I'm overall looking at this as a social justice moment in an education, in a medical education. I look at queerness and non-normativity, and of course, due in part to my identity and my interests, I also look at gender identity. So some ways that GTAs sort of bring in transness. For one, they just talk about trans people. They acknowledge that not everyone who comes in for this kind of an exam identifies as a woman. They adopt language. So instead of using she gendered language, you refer to the patient or people with ovaries. And another way that a lot of change making came up is through self-representing yourself, your bodies and your experiences. There are some challenges to that. So having trans people in this position, of course, we know that there's not a monolith of what one trans body is like, what kind of social or medical transition someone might have engaged in. And some of the biases show up with the program directing people around that. So the folks that I'm going to be focusing on are in settings where there is welcomeness, where trans people are welcomed. One person says, if you feel equipped to teach this session, thank you for being here. It's a fact that we have people who aren't cis as GTAs in our program. So it really has sort of an expansive expectation for who does this work. There's some organizations that are a little bit more trans neutral, which say that technically you can, if you have a uterus and one ovary, that's all you need. But for some reason, people aren't following through. Maybe it's because they don't feel comfortable, as that second quote points towards. And that points to some troubling stereotypes around trauma and transness, where if you're trans, then you're probably not comfortable in your body, and therefore you can't do this, this job that requires you to be at ease in your anatomy. And there are some programs that are outright trans exclusionary, and they don't just resist hiring trans people, but if there is a GTA who does start to transition, they lose them, or they fire them. They say we can have trans people, but once the hormone therapy takes over, then they become differently bodied. So if you're looking for the standard body, a cisgender body without hormone intervention, even though there's a range of hormones in all bodies as it is, then you're not eligible to do this work, which has all sorts of sociological implications. So for the folks who I've spoken to, most of them do identify as non-binary. One is Zora, who identifies as two-spirited, talks about how they voice their identity in the sessions. They say, I use they, them pronouns. I always introduce myself and I offer my pronouns. And I also offer folks the space and opportunity to offer theirs. And if they don't know about that, I'll say a little bit about pronouns and why my pronouns are important. So this is vocalizing their pronouns. And it's very different if you're talking to someone who's saying, some people will use they pronouns, and that's why that's important, versus someone who you're about to give a pelvic exam to, who you're trusting, you're in this setting with, at least to a certain extent, you have to trust them, who is attesting why their pronouns are important to them. It makes it more real. Sometimes the activism happens without even vocalizing it. So as Alex says, one of the reasons I choose to actually wear my beard instead of having a hidden beard is it's just a small daily activism that levels it up when I'm in a particular setting where it really matters. I'm just there being like, your patients might look like me. FYI, you might not have seen me before or people like me, but your patients might look like me, and now you know. This is another instance of pushing against the idea of a standard patient. This is another instance of being normal and healthy and having a beard at the same time. It acknowledges also the range of normal as opposed to this one thing, this one body that is normal it's talking about. It's acknowledging that there's more to it than that, which should be recognized in medical schools, but it isn't always. which is why I want to ask what else could be done with this. If it's working and it feels effective and people are feeling empowered by bringing their identities into the medical institution in this way, what if it was more widespread for trans and non-binary people to do this work? They're literally modeling with themselves that normal and healthy bodies can be trans. Normal and healthy bodies can have gone through hormone therapy or look different or express themselves differently than what a textbook would show you. That said, of course, there's some challenges where what you can only be trans up to a point, right? Is the message that we're receiving from some GTA programs, where if you have had bottom surgery, then, or if you've had a hysterectomy, then it would be hard to show where your ovaries are and what a uterus would feel like from a hand on your abdomen. So it gets stuck in the gender binary that is everywhere in medicine. Even though there's some ways that it can push against it, there are also limitations to the queerness, also limitations through professionalism. Some people...
Si pudieras ir cerrando, por favor, en los próximos minutos.
Please, can you finish in the next few minutes?
Yeah, absolutely. Yeah, the last question, well, what if transness was not the whole lesson that you were teaching, but instead it was just a detail in this previous lesson? So if you're teaching a pelvic exam and that's where the focus is, and you just happen to be trans, what kind of exposure does that bring for medical students, and what kind of representation does it get into medical schools? Thank you.
Muchísimas gracias, Bex, por tu presentación y también por respetar el tiempo.
Thank you very much, Mex, for your presentation and for adhering to the time. Now we're going to Simone Kolysh from the United States, from Hood College. She has a master's degree and a PhD.
Is everyone able to hear me? Thank you, Bex. Honestly, if you didn't do the thumbs up, what would even be the point? In the chat, I wrote a small message to everyone, which reads, hello, everyone. I won't be using a PowerPoint, so just wanted to make sure that you're able to contact me. And I put down my email, which is simonekolysh@gmail.com. That's SIMONEKOLYSH@gmail.com. Or you can find me on Twitter. Several of you asked if you can quote my presentation on social media, and I do give everyone permission to do so, particularly if you quote me verbatim, right? And you can also find out more information about me on simonekolysh.com. So one part of my reproductive journey is joining us right now from Maryland, United States. And this is a 16-month-old baby, yeah, who's talking to you at the moment. And we are coming to you from Maryland, United States, out of our living room, while my wife is getting some of our other children. So maybe after the presentation. And I wanted to say that I'm wearing a black and white flower dress. My short pink hair is off to one side. I have some flower earrings on and a black velvet choker, and the baby's wearing some flowery stuff as well. My pronouns are they, them, so make sure to use them, and I will do my best to speak slowly and directly into the camera. In general, and I apologize for the toddler being a toddler, my backgrounds are in biology, public health, and women's studies, as well as sociology. Elias, why don't you go find cereal? Okay. And I'm currently an assistant professor of sociology at Hood College here in Maryland, but I have worked in biological sciences as well as public health sort of during my entire academic career. And my previous project was on what happens when people are catcalled in the public sphere, especially as women perceived individuals and as people who are LGBTQ. And that work has culminated into a book called Everyday Violence, the Public Harassment of Women and LGBTQ People. And it will be out on September 17th this year. So in thinking about my next project, I was going through a panoramic, as we all are, and I had a pandemic baby and thought about how lucky I was to have a home birth attended by trans competent doula and midwife, a friend, and my wife, and to have the kind of birth experience that I didn't have previously, and to come to terms with the fact that I faced a lot of obstetric violence in my previous labor experiences and pregnancy experiences. And so I started thinking a lot more about going after, as a sociologist, I always go after somebody, going after the healthcare industry and to try to figure out the structural reasons people are dying, the reasons for maternal mortality, the medical neglect, the medical racism, medical fat phobia, and all the intersections of these oppressions. And just to start thinking about the history of the medical industrial complex in the United States, but also around the world, and the way it follows very specific patterns. Okay, we're having a little tantrum again. And the patterns that it follows is that we take people's knowledge and understanding and agency and autonomy away, and then sort of place it in the hands of folks in power, who then get to tell you if you're feeling pain, if you're really sick, if you have the right to make decisions for yourself. So when I started to think about just focusing on transgender and non-binary people, are you okay? Do you want to come sit on me? Or you want to watch Coco Melon? I, sort of put out a call for participants, for folks who are trans and non-binary, who have had a variety of reproductive journeys. They certainly did not have to have children. They just had to have some thoughts about their gender and about their reproductive capacity, or someone else's, that is. So it's pretty broad. And I'm just moving through my notes here. And, I sort of took a look at the literature and saw that there was some conversation about transgender men, having children, and also in the media being sensationalized for doing that. Or there were some, stories about couples who are both transgender and they used each other's gametes, to conceive their child and start a family. And now you're hearing my dog too. Katerina. I love that this is going to be on YouTube as a slice of life kind of video. Let me actually, maybe I'll close the door. Katerina. This is how the pancetta has been, including when teaching. And there was a lot fewer stories and research on trans women and trans feminine people, trying to figure out this landscape. There was also, when I took a look at the literature, this kind of, as I wrote in my abstract, disproportionate focus. Katerina. It's because there's other dogs and there's a conflict. Give me 1 second. Come on. Yeah, we're presented on a global stage. So there was a lot of research about what cisgender people believe should be happening around transgender people's reproductive paths and pregnancy. And of course, I find that to be a problem, because when our stories and our experiences and our facing discrimination is left to cisgender researchers and cisgender healthcare professionals to define, we get into this issue that I'll discuss in a minute called transnormativity and the various other rigid paths that people ought to take, not only as they become authentically themselves, but as they figure out their reproductive journeys. And so I wanted to do this project as an important corrective to this issue, and also because Twitter picked it as a topic out of a couple of options. And I'm passionate about a variety of topics, and this one was just something that other people believed was not a topic that is explored a lot. And it's sort of something that people are interested in. And just as much as we sort of work towards people's choices and abortion access and reproductive rights, you know, transgender people like myself and others deserve to start families if they wish. And it shouldn't be an anomaly, and it shouldn't be an experience full of violence or potential death for any reason. And so, you know, it became a much bigger kind of endeavor. And so, let me just move around. I just wanted to talk to people. I conducted about 45 oral histories right now with trans and non-binary folks, as well as doulas and midwives. And I expanded the focus to all over the world, because I believe I can, you know, at least figure out how to talk about global inequality and differences across the world without making, you know, generalized statements. But one of the statements that we can make is that healthcare as a setting is a kind of gatekeeping institution. It doesn't only gatekeep whether or not we can transition if we wish to. It gatekeeps if we're able to thrive in general. You know, it kind of reduces all of our health issues to our being trans or non-binary. And I define trans pretty broadly. I should have said that at the beginning, as defining people whose gender today is not the gender with which they were raised or assigned. And for me, that includes non-binary people. But it was really important for me to, when thinking even about the title of this talk or the title of the book that's coming from this research, to specifically state that it's about transgender and non-binary people, because transgender is a term that really comes out of this white Western colonial framework. And it's not something that's accessible to people or even something that others want to use for themselves. And non-binary also has similar issues. But at least when you see that phrase, you think, okay, maybe this person is attentive to all of these differences under the umbrella or around the umbrella. And this will come up also. Can someone please tell me my time?
Yes, I was going to tell you, you have 5 minutes left, but you can also
Perfect.
take a couple
Thank you
extra
so much.
minute or two
So,
if you need it.
in the remaining 5 minutes, I'm going to talk to you about the way I started organizing this book in my head that's coming out of this. And I realized that it's gonna be sort of a chronological story of any one of us, and that all of our journeys, both trans and reproductive journeys, start out with us as children, obviously. And so those initial experiences with healthcare, particularly as it relates to reproduction, maybe the first time someone went to the gynecologist, maybe the first time they experienced, you know, sexual assault, or just sexual violence in general, already influences not only just how they'll think about gender, sexuality, sex, their trans identity. It influences whether they'll ever go to the doctor for any reason, but certainly for something like a gynecological visit. Because what I've learned, and one of the conclusions of this study, is that there are not many trauma-informed settings, but especially when it comes to reproduction and reproductive health. And you would think that providers within reproductive health areas would know that they are to be better trained, more equipped, you know, to sensitively address those experiences. And I've heard horror story after horror story of, you know, cis, white, straight men gynecologists re-traumatizing people. And when that takes place, just like in my previous research, it just brings up muscle memory and memories in general of all the other times you were not in control of your body and of your experience and were not believed and were dismissed. So it's actually a really vulnerable place to be in. And and I have my notes that transnormativity is everywhere. And it's interesting because many people don't understand what transnormativity is, including trans people. And so I'm going to define it as this hegemonic narrative, this overarching story of how trans people are trans. And we can blame the media, and we can blame each other, and we can blame the Instagrams and whatever. But ultimately, we're all faced with expectations, whether they are by cis people or trans people, of how our articulating our gender is going to look like. And that means some people are asked often inappropriate questions about when they're going to go on hormones, or when they're going to have top surgery or bottom surgery, if they are even using terms like that, let alone inappropriate terms, you know. And when people are non-binary, you know, they never feel trans enough, quote unquote, I'm using quotation marks here. And these are ongoing conversations. And so when we get to other structures like medicine, for example, it's evident there too, because if a trans man, for example, wants to go and have a conversation about getting on testosterone, there are a lot of assumptions doctors make about how he obviously wants his uterus removed, which is not the case for everyone. And when I talk to some providers about like why they kind of push that narrative, which excludes a variety of options out there for people, they said, well, I feel very much like this, it's not my place to sort of insert nuance here, and like it might offend some trans men for me to remind them that this is a body part that they have, because we gender people's bodies, we gender people's organs to such an extent that it could be dysphoric for someone to think about their uterus. And so this is a larger problem anyway, because everything that has to do with our bodies needs to be ungendered in order for us to receive care. So this is true of cancer care. This is true, you know, there was just an article I read yesterday about how someone's brother died of ovarian cancer. And of course you expect all of these comments, and they were there because people were confused about how someone's brother could die of ovarian cancer. And, you know, they buried the lead, right? And talked about how this is a trans man and, you know, had ovaries and had ovarian cancer and died. And, you know, the article gained traction, obviously, for its shock value, but it's not shocking to have ovaries and to have ovarian cancer. It's actually under-researched and underfunded, and, you know, not discussed even for cis women, and it's certainly not thought about when it comes to the LGBTQ community. And so we have a lot of data showing those kind of gaps. So I was hoping to, you know, unpack that with some people. I also wanted to say that there's a huge variation under the trans umbrella. And so people experience a variety of things. For example, non-binary people with a uterus who want their uterus removed, but are not saying they are a trans man. Do you see him on the wall trying to take my art down? It's unbelievable. Anyway, I'm gonna go fix that later. Yeah, I see you. Yeah, you're a big, tall baby. And they were denied having their uterus removed because there's a potential for some heterosexual union in the future, and some man might be angry that they can't get you pregnant. So there were really archaic notions embedded in these interactions of compulsory heterosexuality, of just cis-sexism, of just nonsense that had nothing to do with medical science in the way that doctors believe they're doing it, okay? And so finally, I just kind of wanted to talk about trans competency and what it means. We use those terms a lot. And trans people have noted that there is a superficial way of achieving this, and there's a meaningful way of achieving this. And the superficial way is when, you know, you can have maybe here, put your pronouns down on some form or a sticker, but the pronouns aren't used, and they're not affirmed, and they're not respected. And it's just sort of like tokenizing, and it's very one-dimensional. And real trans competency is something I'm articulating in this work as we go along with other trans people. And it really, well, obviously includes structural changes, but also it has trans people in the office. It has trans physicians, trans doulas, trans midwives, you know, it has trans staff. It's really valuable for people to obviously be among their own groups of people. And, you know, and it also has to have other diversity represented, obviously. There's a lot of intersections in this work with racism and sizeism and ableism and mental health illness, like stigma, you know, that is beyond the scope of this presentation, but would also need to be disrupted in these healthcare settings in order for us all to thrive and to start families if we wish to, and to remove our reproductive capacities if we wish to. Thank you.
Muchas gracias, Simone. Muchas gracias por superar.
Thank you, Simone. Thank you for overcoming those difficulties that you had during your presentation. It was good. I'm just wondering if Ruth, Pearce, and Tash Oakes, are you connected?
Yes, we were going to play a pre-recording. I hope that's okay.
Sí, sí.
This should be here.
Hello everyone, and welcome to our presentation on inequalities in perinatal healthcare for trans people in England. My name is Tash.
I think we stopped listening to the audio. Is that possible?
So today we're going to be talking about initial findings from the ITEMS project, improving trans experiences of maternity services. And we're using trans here in a way that is inclusive of non-binary and genderqueer people. And this was a collaborative research project led by the LGBT Foundation, involving organizations such as the National LGBT Partnership and also the Trans Learning Partnership, of which I was a part when the research took place. And it was funded by NHS England. And the context for our research is that in England, NHS midwives are available to all birth parents for free. And this is through the perinatal period, that is covering pregnancy, birth, and post-birth. However, there's not any existing research or guidance, specifically in the English context, on the needs of trans birth parents. So this research sought to
Ruth, would you mind turning off your microphone? I can hear you typing and I cannot hear the audio. Would you mind turning the audio up a little bit? I'm so sorry, but I can barely hear what the audio is saying. I'm very sorry.
I'll try again. Sorry, I tried muting and it didn't turn up. I'm going to try pressing play again.
Yeah, thank you. I'm so sorry to interrupt.
So what we did was we undertook a mixed method survey, and this included statistical.
Sorry, Ruth, you seem to have muted yourself. I can't hear you at all now.
On findings from the survey.
Nope, it's back.
Are you, so in your share screen options, did you click share with sound?
One moment.
So if you go up to the banner at the top and then options, you should have share with sound. And then if you do that, you should be able to play the video and mute yourself, and we should be able to hear the audio.
You mind if I start again from the beginning?
That should be fine.
Thank you.
Hello everyone, and welcome to our presentation on inequalities in perinatal healthcare for trans people in England. My name is Tash Oakes-Monger and my pronouns are they, them.
My name is Ruth Pearce and my pronouns are she and her. So today we're going to be talking about initial findings from the ITEMS project, improving trans experiences of maternity services. And we're using trans here in a way that is inclusive of non-binary and genderqueer people. And this was a collaborative research project led by the LGBT Foundation, involving organizations such as the National LGBT Partnership and also the Trans Learning Partnership, of which I was a part when the research took place. And it was funded by NHS England. And the context for our research is that in England, NHS midwives are available to all birth parents for free. And this is through the perinatal period, that is covering pregnancy, birth, and post-birth. However, there's not any existing research or guidance, specifically in the English context, on the needs of trans birth parents. So this research sought to find out more about the experience of trans birth parents in order to inform midwives, and we will also be producing recommendations. So what we did was we undertook a mixed method survey, and this included statistical data collection and free text box for qualitative data connection. We also undertook qualitative interviews, although today we are going to be focusing on findings from the survey. And the design of our questions was deliberately done to align with the design of the Care Quality Commission Maternity Services Survey. And this is a national survey which is done to find out the experiences of cis women who give birth. So we wanted the experiences of trans men and non-binary people to be directly comparable with women. Another thing we did with the design of this research was targeted recruitment of trans people of colour, which I'll be looking at in more detail in a moment. And our analysis is in progress. So today we'll just be looking at descriptive statistics from the survey, but we're planning to do a full statistical analysis in the future. So here is an example of some of the targeted recruitment and incentivization for trans people of colour to participate. This was really important for several reasons. One was that, as writers such as Cyrus Marcus Ware have pointed out, from a perspective of a Black trans parent, there are experiences that trans people of colour have at the intersection of experiencing potentially racism and transphobia that white trans parents will not have. And secondly, trans people of colour are underrepresented in most trans healthcare research in the UK, and also in most research internationally on pregnancy, fertility, and childbirth to date. So in collaboration with our colleagues who are trans people of colour and queer people of colour within organisations such as the LGBT Foundation, we used approaches such as this poster to ensure recruitment of people who saw that actually we were interested in having their experiences and their lives captured in the research. And we were also paying people for their time to recognise that it can be quite a lot to take part in work like this. And so I'm going to talk briefly about demographics. We had 121 eligible responses, which means, as far as we're aware, this is the largest survey of its kind in Europe. The mean age of trans birth parents was 31 at time of birth, which broadly reflects what we know. It's quite similar to women who give birth. 29% of participants were disabled, which reflects what we tend to find with the wider trans population. And in terms of ethnicity, we ended up with a sample which we felt that the process of intentional recruitment of trans people of colour was broadly successful. We've got a graph here where the terminology we've used is in line with what's usually used in British research, such as the Maternity Services Survey, although some of this language isn't what we would have preferred to use ourselves. And so we're hoping there's a way of using having more community input into design a survey like this in the future. We're quite pleased with the diversity of the sample, but Asian and British Asian trans people were underrepresented, and this is something to address in the future. In terms of sexual orientation, the majority of participants were bisexual, pansexual, or queer, which again reflects wider trends within trans communities in the UK. And we were also really interested to see that there appeared to be an increase in trans people giving birth every year, which reflects anecdotal observations that people have been making for some time. So it was quite exciting to get data on this. So next we're going to move on, and Tash is going to talk about our main finding.
So yeah, this was one of the main findings of the research, and a really interesting one. So 30% of respondents in our sample did not access any support from NHS or private midwives during their pregnancy or pregnancies. So this is sometimes called free birthing. We don't have many statistics on free birthing. However, we do have a comparable statistic from the ONS 2019, which found that 2.1% of women who gave birth did so at home. So obviously this statistic includes those who had access to maternity care but chose to give birth at home, and also those who gave birth before they could get to their birthing place. So the real number of women free birthing, or more accurate number, is probably lower than this. So the reason we were interested in free birthing in particular is because free birthing carries some extra risks. So because of the nature of free birthing taking place outside of the healthcare system, we don't have much data on risks associated with this. However, researchers suggest this may be similar to the risks associated with births before arrival. So births before arrival are where someone has given birth before they get to hospital, so they give birth without a midwife present. And risks associated with births before arrivals are blood loss for the birthing parent and a failure to maintain body temperature for the baby. So this was really important given that such a high proportion of our sample were free birthing, and this proportion was even higher amongst trans people of colour, with 46% experiencing free birthing compared to 28% of white people. This is particularly an important finding because of what we already know about people of colour in pregnancy, and the 2020 Embrace report finding that Black women were over 4 times more likely, and Asian women twice as likely, to die in childbirth compared to white women. So that was really important. So we decided to look into the experiences of free birthing a bit more. So initially, a finding here that the desire to free birth was quite high amongst our sample. Almost 65% of those who did free birth wanted to free birth. However, when we looked at those that felt that free birthing gave them the experience they wanted, this number was slightly lower at 52%. And then those that would free birth again was lower still at just 43%. So it was important for us to look into a bit more, perhaps the reasons behind why we had such high numbers of free birthing. And we found that of those who free birthed, 30% of those people agreed that they would not have considered accessing maternity services. Almost 40% said they would have been uncomfortable accessing maternity services, and only 20% of those who free birth reported feeling confident to access maternity services, even if they felt that they needed to. So this was a really important finding for us because it suggested that a large motivator for free birthing was discomfort in accessing maternity services. So part of the reason why we thought this was important to look at is that there is a lot of data amongst cis women that shows that people are free birthing as part of an active choice to do with empowerment. However, we found that roughly half of our sample who free birth agreed that it would have been helpful for them to have a midwife there to support them during pregnancy, labour and birth, and in aftercare. And that, coupled with the feelings around maternity services, suggests that free birthing in this population is actually largely motivated by a desire to avoid maternity services rather than not wanting a midwife to be present. So further research could focus on whether this reluctance is associated with discomfort around maternity services and the level of training that midwives may have around trans people, or whether it's more specifically to do with the hospital-based environment. As if this is to do with the hospital-based environment, there may be a lack of understanding or knowledge around the services that are actually available to trans and non-binary birth parents, such as the opportunity for a home birth.
this idea around the possibility of negative experiences in hospitals was actually borne out in a lot of our data on people's experiences of perinatal care. Respondents reported a range of experiences. Many had very good experiences and felt supported by midwives who were really focused on person-centered care. However, many also responded negative experiences. And one common issue was misgendering. And we can see a graph on here saying that only 41% said that they were always spoken to in a way that respected their gender. This is likely to impact the health of the parent and the baby. And Tash, you were going to talk a bit more about that.
Yeah, so I think this is one thing that we really pulled out, because obviously misgendering can contribute to depression, anxiety, and low self-esteem. And we know from research and evidence that depression, anxiety, and stress during pregnancy can result in miscarriage, in low baby birth weight, and consequences for infant development and into the future. So this was really important as a finding for us.
We also found that trans people appear to be more likely to receive inadequate care across the board when compared to cis women, and we're going to return to some that in a minute. But first, here's a couple of quotes from research participants that are really digging into that question about misgendering. The first from a participant who described themselves as non-binary, no gender, queer, black, and disabled. And this participant said, "I felt there was no framework of language that was inclusive of people who do not identify within the gender binary, so it's consistently a triggering experience." We also had a more complex accounts from some participants who had bad experiences but potentially downplayed some aspects and not others. So, for example, a participant who described themselves as non-binary, transmasculine, and white said, "I can't praise my mental health midwife enough, despite the fact she frequently misgendered me. But the rest of the team didn't really acknowledge or take into account my transgender health medical history." And this reflects findings by researchers such as myself and Ben Vincent, showing that trans people often downplay negative experiences or are prepared to accept certain experiences as acceptable because they're so used to having bad experiences of healthcare. So a very quick look at some examples of the findings comparing trans birth parents to cis birth parents. We asked, thinking about your antenatal care, were you involved in decisions about your care? And 62% of trans birth parents said yes, always, compared to 82% of cis birth parents. And similarly, when we asked about labour and birth, were you involved in decisions about your care? Only around half, 53% of trans birth parents said yes, compared to 82% of cis birth parents. And we had many more findings like this in response to a lot of the questions. So in terms of next steps, we're going to produce a full statistical analysis and report looking at these numbers in a deeper way. We are also planning to produce recommendations for midwives and service providers. These are going to be co-produced with birth parents and birth workers who are involved in the items project. But we'd also like to know if you have any proposals. So we're going to put a Padlet link into the Zoom so you can have a look. We're also going to do an academic write-up of our findings. Finally, and we're going to put this in the Zoom and also into the conference program. You can find some resources produced through the NHS by the Brighton and Sussex University hospitals on how to support trans birth parents in practice. So those are some existing NHS resources. And there's also some resources available from the Trans Pregnancy Project, which I was previously involved in. Thank you for listening.
Thank you.
Muchísimas gracias, Ruth y Tash.
Thank you very much, Ruth and Tash. And now we will move on to Marce Gutierrez from the School of Social Sciences in Buenos Aires, Argentina. Marce, you have the floor.
Okay, thank you. I'll be sharing my screen now.
Bueno, no entiendo cómo se comparte la pantalla. Ahí está.
Let's see if I can do this.
¿Se ve mi pantalla?
Can you see my screen now?
Sí, se ve la pantalla entera.
Yes, we can see the whole screen. Can you please set it to present?
Eso. Bueno, yo voy a presentar un pequeño trabajo que es más
I
que
would
nada
like to present a study on, it's a reflective study on debates that we had in Argentina when we fought to legalize abortion. I will start by sharing an anecdote which is significant and led me to make this presentation. A day after this law was passed in Argentina, December of 2020, this termination law, I posted this on Instagram celebrating the law in spite of all the differences we might have had with the final drafting of the law. And a non-binary friend who lives in Barcelona replied to the story very happily, and he couldn't quite believe that there was a law about the right to abortion and that establishes that anyone that can have a baby is the subject of the law and not just women. Of course, the context in this area is quite negative towards trans people. And there are other legislations or other bodies of law that actually refer to women. And many times they use some words such as motherhood and notions that are closely linked to cisgender heterosexual femininity. And this is never questioned in laws. Laws never deal with trans people. And there was something else which was very interesting. This whole debate in Argentina that led us to have a law that talks about people that can have babies. This is not just expressed in the abortion law, and it was like the feminist movements and sexual dissidence movements actually fought for this. But this is also part of other laws that deal with birth, gestation, and that has to do with being mothers or fathers or parents in this society. This is law for voluntary pregnancy termination. It's law 27610, passed last year. It states that the subjects of this law are women and other people with other gender identities that can actually have babies. There were many debates in this regard when drafting the law, because there was this supremacy of women as a natural and authentic subject of abortion, and all the other people were part of a secondary group in a way. The Argentinian president submitted another law, the 1000-day law, which in a way represents the opposing political sector, the one that opposes feminism. It had to do more with conservative, pro-life sectors and anti-abortion sectors that in a way wanted to provide guarantees for those who wanted to keep their pregnancies. And it's funny that in this law, they also use this terminology in Spanish, persona gestante, or birthing person, or also because it includes people that can also have babies and not just women. This led me to think, where else in the Argentinian system have we used these expressions, and what does this mean? What does this entail for our activism in the future? This whole debate on the inclusion of other identities within the right to abortion in Argentina was a broad and complex debate.
Mencionó Fran, yo formo parte de una cátedra.
As Fran has said, I am part of a department of on the right of abortion at the University of Buenos Aires, Social Sciences. I also studied in Salta and was part of the department, and I am also part of the campaign within a space that includes dissidences and also a network of university departments for the right to abortion. And we have been very close to this idea of who is the subject of an abortion. Before 2018, this issue had already been problematized, and in 2018 the debate really peaked because there were several street demonstrations that included many people, and they actually pushed for the right to abortion. Probably most of you don't know that this campaign is a political bloc formed by several non-governmental organizations and also by political parties that since 2005 have been actually addressing these abortion bills, and they have been influencing feminisms in Argentina. This is a peculiar and complex political structure that has been working for 16 years around this right, the right to termination, to terminate a pregnancy. At some point, it was clear that this campaign space included mainly heterosexual women, and that did not really consider the trans needs and the right to abortion as well. This became a heated debate in 2018 when the topic was debated for the first time in Congress. And this meant that we needed to consider each item in the law very carefully. This gave rise to larger tensions regarding how we were going to mention these identities. Would they be called personas gestantes, as in birthing bodies, birthing parents? Someone talked about saying women and anyone that can actually have a baby. It was a whole debate on the terms on the use of the words, on their influence as well. And this is very important because it's what I would like to highlight here. We had the national campaign for the right to abortion. I will not delve into this, but they've been working for a long time, for 16 years in Argentina. Before them, we had the commission, which was created in 1987. So Argentina has quite a long history in its fight for the right to abortion. There was another case that I researched and worked on, and it is recognizing our trans identities on identity cards, national identity cards. Usually in Argentina in 2012, a gender identity law was passed, and it allows us to change the names on allows us to change both our sex and the change and the picture as well. And that has enabled trans people to access the health system. Many times it was very difficult to access the health system because our ID cards didn't represent us. So these men and the new ID cards have helped a lot. But there is a story before this law that hasn't been properly addressed. On the right, we have a picture of Karina Urbina, who is a trans activist. In 1982, she actually spoke before a court to request her ID card to be modified and to request access to gender affirmation surgeries, because at the time they were not allowed in the country. It was strange because it was only until 1989 that the justice actually responded to her. Justice is very slow in Argentina. Justice issues a ruling in this regard. There are 3 judges in the court, and one of them votes differently and supports, in a way, Karina's claim. What is interesting about this is that there will be a number of debates in different congresses on family law, civil law, or different debates on this topic. So the justice begins to talk about what to do with trans people. You have 5 minutes. Okay. In a way, these debates created a new scenario where, and many years later, 1997, Mariela Muñoz, another trans activist, finally is awarded her ID card. Okay, there's not much time left. I briefly wanted to say that all these debates regarding the terms used in the laws are really considered. I believe that access to health and the well-being of our community have more to do with practices. I understand that, how we are treated, how we're really treated in health environments. But it's also important to remember how this debate on persona gestante or birthing person is also important, and how it affects other areas. Currently, the communication sector of the Ministry of Health talks about birthing parent or birthing person when they talk about other topics. Even in bills of law that have been created by conservative sectors opposing abortion, they have used the term persona gestante, as in birthing person, in the drafting on the law. So in a way, the debate we had at the time during the fight for abortion has actually included this very complex subject, of course, difficult to understand, but it, in a way, it sheds light on it, and every political sector uses it, those in favor and against. Currently, new bills of law are being debated, for instance, maternity leave, adoption, bills that have to do with respected births, etc. A number of bills of law that are being addressed and that have to do with reproduction, family, and birthing. They are using this expression, mujeres and personas gestantes, or women and people who have the capacity to birth. And this is very important because it pushes the limitations or the limits of that society imposes. Of course, we have a long way to go in Argentina, but it's very peculiar to see that we have avant-garde laws which are then not implemented, but oh well. I believe that the fact that this is expressed in the laws and in different places also talks about the success of our debates as dissidencies, as transvestites, as trans, as transgender, as non-binary people within the campaigns, feminisms, the fight for abortion, fight for the right to abortion. So we have been able to create this new subject in a way, and this is really a success story. We need to see how we take this from the field of laws to practice itself. This doesn't happen in all legal systems, and I believe that it is something very peculiar in our system. Thank you very much.
Bueno, muchísimas gracias, Marce, y al resto de quienes expusieron hoy.
Thank you, Marce, and thank you to all of you who have presented today. Now I would like to read some of the comments you have made in the question and answer session. This ends at 2 o'clock, and after this we will be opening the new session that begins in around 20 minutes. Q&A. These are comments, actually. I will start with the new one, with the first one, sorry, regarding reproductive rights. We need to change this idea of heterosexual idea of pap smear, birthing, etc. And we need to also include other sexual orientations. Also, as Anne Millet said, it's not that we know a little or a lot about trans health, but rather that medical practice focuses on excessive knowledge of cis-sexual health. Okay, there's another comment in Spanish by Daniela Ruiz, who says that it's very important to talk about trans and transgender and transvestite in the Latin American context. And another one in English.
Who says, doctors making assumptions. Seems like this is part of the larger medical system, at least in the US, seemingly, to make dichotomous binary choices about whether someone is well versus unwell, male versus female, etc. This can be coded as affirming care, quote unquote, affirming care by MD, like medical doctors, and OD, which I guess is obstetric doctors, I'm not sure. Seems like teaching doctors and medical staff to hold tensions and assumptions is in opposition to managed care models. Bueno, y creo que eso es todo lo que tenemos hoy, ya en unos pocos minutos.
Okay, I think that's all for today. Let's see if everyone else has something to say, but we'll see each other in a few minutes in the one but last session of the day. Thank you.